Thank you, dear Chairman, colleagues. I would like to thank the organizers for having me here. I'm Dr. Shairf from Iran. I work at a heart transplant center in Tehran, a city when there's no pollution looks very good, but usually we've got lots of pollution. I'm going to talk about renal involvement and heart failure. We know that if you work in a heart failure clinic, you'll see lots of patients that have renal involvement. And if you work with a kidney transplant clinic, you'll find lots of patients who have heart failure, even asymptomatic. They are linked together. And when we have bi-organ failure cases, the prognosis gets worse. When both organs are involved, we have a worse prognosis. When both organs are involved, therapeutic and diagnostic options change. We have limitations when we've got these kind of patients. Not all the tests run as good as before, not all the medications can be used. And one of the things that we don't have is our clear-cut guidelines, what to do when we've got bi-organ failure. Going back to definitions, because that would help us to define what we want to do. In 2004, the National Heart, Lung and Blood Institute gave a definition about cardiorenal syndrome as a state in which therapy to relieve heart failure symptoms is limited by further worsening of renal function. That was a very simple definition, really easy to remember, but it was too simple and we would have problems in defining lots of our patients. It's not only the therapy that is limited, and it's not only heart failure that is getting the problem. Sometimes it's the other way around. We have patients who have renal disease and cannot be treated accordingly because of the heart failure. So we have a bidirectional organ injury, not a one-direction one. So the 5-type kind of classification was given. I should say I'm not a nephrologist, so I don't look at these types like they do, and I don't really give that much attention sometimes to it. But we have the cardiorenal syndrome, acute and chronic. We have the renocardiac syndromes, acute and chronic, and the secondary cardiorenal syndrome, where some other kind of disease is harming both the kidney and the heart. Here it's the heart, cardiac function that leads to kidney decreased function, and in these two we have the kidney that is harming the heart. To help us see what is happening, we could use this slide. It gives us lots of mechanisms in the chronic kidney disease, stages 1, 2, 3, 4, and 5. You can see there's anemia, malnutrition, we have inflammation, we have overload of water, sodium, we have anemia again here, uremic toxins, we have the uremic cardiopathy that could be seen here, smoking, obesity, hypertension, dyslipidemia, and chronic inflammation. All of these could start and harm the heart also, and vice versa. We'll have this cycle, and what is not shown here is this is a vicious cycle. When it starts, it just doesn't go around one time. It goes around and we start losing more kidney and more heart cells as the disease progresses. To make it easier, we can show some of the mechanisms here and see how much they do affect the kidney or the heart. Hemodynamic abnormalities, low renal blood flow, or increased renal venous pressure, which is now the main component of what they think is harming the kidney in the CRS type 1, can cause renal injury in heart failure. The neurohumoral activation, either the sympathetic activity or the renin-angiotensin system, both heart and kidney are involved. We have inflammatory activation and oxidative stress in both of them, but in the coagulation fibrinolytic system we have damage to the heart, which is started by the kidney failure. Vascular calcification is also seen here, and anemia, as you can see, can cause heart failure in patients with chronic kidney disease. One of the interesting parts is the diuretic treatment of heart failure. We'll talk about it a little bit more in the future slides, but interestingly, the CRS type 1, the one that the kidney starts dysfunctioning in an acute heart failure situation, usually happens when the patient is hospitalized and receives the diuretics. That's interesting. But what do we know about the prevalence and some other facts? Up to 40% of patients hospitalized because of an acute decompensated heart failure develop acute kidney injury. 40%, that's near half of the patients. As I said, it rarely occurs in pre-hospital patients. It seems that when we start giving diuretics, it's when the kidney function starts to decline. And this is a problem because we say the reason that the kidney is having the injury or being injured is that we have congestion. And to take that congestion away, we have to give a diuretic. But when we start giving the diuretic, we get the problem, well, we make the problem worse. And if you debate a nephrologist in this situation, usually they tell you, forget about the kidney, try to treat the heart. But really, as a cardiologist, it's a little bit troublesome and makes me worry about the patient because I know if I lose the kidney, then treating the congestion will be really hard. So it's kind of balancing the good and bad bit in this situation to give the diuretic as high as possible, but not in the high dose that would make permanent kidney damage in these cases. There are other types of kidney injury in the acute setting. If we use contrast media to do an angiogram in this patient, some of these patients need an emergent kind of angiography to go forward or do a PCI on them because they are presenting with an acute MI, let's say, or if we do a bypass surgery, we could have kidney injury. Also, other medications here could be responsible, but as I said, the diuretics are one of the most important ones. In chronic heart failure, what do we know? There are risk factors that are both affect the kidney and the heart. Diabetes and hypertension and smoking are very important in both cases. About 30% of these patients who have a chronic heart failure show evidence of chronic kidney disease to an extent. We don't say all of them are really in the end stage 5 or needing a transplant, but they do have changes in their kidney function. And what happens is when we have kidney failure, any type of it, it is related to the prognosis, either to the complications or arrhythmia or hospitalization. And in some studies, it has been shown that it is one of the most potent prognostic factors in a chronic heart failure patient when you have kidney disease. Vice versa, what happens when we have renal disease? About 80% of patients with end-stage renal disease have cardiovascular disease. It is the leading cause of death in patients with end-stage renal disease, either due to heart failure, ischemic heart disease, or other cardiovascular catastrophes like sudden cardiac death. Even in patients who do not have evident kind of cardiac disease, we could have signs and symptoms of heart failure because of the overload of fluids that these patients have. So it's really hard to say when it is really heart failure or not. Because of this, some authors do suggest to use a kind of evaluation system based on functional class pre and post ultrafiltration to see if, let's say we could do an exercise test or a 6-minute walk test, something like this, to see if the patients are really in heart failure or how much the prognosis is, or to determine the prognosis in conjunction with echocardiography. So when you're treating a patient with renal disease, with chronic renal disease, you have to remember that sometimes the symptoms are not really due to heart failure itself, and it could be due to the severity of the disease. It would be good to have a biomarker to say or see how these patients are doing. Biomarkers could help us to have a better prognostic view of the disease and to determine which patients are doing worse. But an ideal biomarker would be independent of muscle mass, something that creatinine isn't, reflect the actual renal filtration rate at the time of measurement, and be sensitive to changes in the actual GFR. There are lots of biomarkers being studied. Here are some of them, the catalytic iron or cysteine C, and some other of them are here, lots of them. As I said, I'm not a nephrologist, but I hear them every day when they are talking about them. The three here, the NGAL, the KIM1, and the NAG, are some of those that seem to be more promising. We have to wait to see in the future which one can pass the test to get a better result and be used in the setting of kidney injury and heart failure. But right now, they are being used mostly, as I said, they could have prognostic value, but they do have limitations that are stated here. Talking about heart and kidney, one would think about ultrafiltration in the treatment of heart failure. Well, we do have congestion, we do have signs of overload. Would it be better to use ultrafiltration in the treatment? I know it's going to be a topic of lectures in the next sessions, but what we do know in these cases, there's lots of data that do not stand together. We don't have concrete evidence that is it good or is it bad. In one of these studies, there was a step pharmacological therapy algorithm, and it was, if not less, but it was superior to the ultrafiltration in preserving the renal function. What we should remember is, if the patient is critically ill, you should go for the ultrafiltration in the end stages, but you have to not use it easily, just like inotropic drugs that we can't use for all heart failure patients, but will be life-saving in special cases. Another interesting aspect of the kidney involvement would be the sympathetic activity. We know that we are doing sympathetic denervation for hypertension. The results, some of them are good, some of them aren't really so interesting. But they saw that reduction of sympathetic hyperactivity by nephrectomy, when they were doing the transplant, could help reduce the hypertrophy, and they came to a conclusion that if in these cases, the patients who are going to have renal transplants, if we would do a sympathetic denervation on the kidney, on the patient's kidney, it could help the patients. But as I said, this is in renal transplant recipients. We don't know if we could do, let's say, radiofrequency ablation in heart failure patients to see how it works. It's a question that some of the papers said that it would be useful, but we need more evidence to decide on this topic. Another topic that comes in mind when we are talking about the cardiorenal syndrome is the cardiorenal anemia syndrome. Many patients who have heart failure also have, and renal failure, have anemia. And when we have anemia, the prognosis is worse, even worse than when we got the two of them together. We do know that giving iron, IV iron, could help heart failure patients. We do know that using erythropoietin could help patients when they are in renal failure, but do we have concrete evidence to help us decide to give both of them to heart failure patients? It seems in cases that have a severe kind of anemia, it could be worth trying, but we need, again, more trials in patients who have both of these diseases together. When we do kidney transplants, even if we have severely reduced cardiac function, we might see an improvement in function after the transplantation. And this is the point that makes it hard to make decisions, because when you are consulting a transplant team, they ask you, can we do a transplant on this patient? Does he need to have a heart kidney transplant or not? And you're seeing a patient with, let's say, an ejection fraction of 25%, 30%, but his main symptoms are coming from the renal failure. And this is the reason that you can't go on and say, yes, all patients with heart failure and kidney failure should have a heart kidney transplant. When to choose to intervene, or the cause and effect relation between the cardiac and the kidney dysfunction is not easy to predict, so that is making it even more. And at which point should we consider combined transplantation? I didn't find any guideline to give me that answer. When and where can we do heart and kidney transplant safely? If we do a heart transplant, what will happen to the kidney? The calcineurin inhibitors, you know, are nephrotoxic. We have other drugs that are nephrotoxic, especially in the acute phase after the transplant. We are giving different kinds of antibiotics, lots of other kinds of medications. We have a hemodynamic change and shift during the transplant. Many of these patients experience a kind of a hemodynamic loss, let's say blood loss, or the vasoreactivity that is lost because of the medications used before the transplant. So these could have deleterious effects on the kidney. If the patient, as we said, lots of patients do have renal disease because of the chronic heart failure. So we have pre-existing renal disease, and then we have hypertension, diabetes, dyslipidemia, and anemia. So patients who go for a heart transplant could and will show signs of kidney disease after the transplant. And as time goes on, the extent of kidney failure and the amount of kidney failure does increase. So it's not unusual to see a heart transplant patient who has a creatinine level of 2.5, let's say. As I said, it would be nice to know what to do when you've got both heart and kidney disorders and do a heart and kidney transplants. We don't have the precise guidelines needed for that. And as I said, there's a chance of improvement after transplant in the function of the other organ, so that makes it even harder to make the decision. And we do have papers that show that in selected patients, positive effects of combined transplantation does exist. If you do choose the patients correctly, if they are suffering from severe heart failure and severe kidney involvement, then they would have positive effects. It's not good to have a heart transplant with severe kidney disease or vice versa. In Iran, we've had 2 centers doing the heart kidney transplant. We did the first one in 2011, and the patient is doing quite fine right now. Altogether, we've done about 8 heart kidney transplants in Tehran, and to my knowledge, only 2 of them we have lost, so it's 2 out of 8. But although I said that we don't have guidelines to show which patients are eligible for heart kidney transplants, there is a way of saying which patients will not benefit from it. So if we have a patient with renal dysfunction and heart failure, by using these prognostic factors here, history of peripheral vascular disease, recipient age older than 65, non-ischemic etiology of heart failure, a bridge to transplantation with a VAD, and dialysis dependence at the time of transplantation. And adding these scores together, you can decide if the patient is going to benefit or is not going to do good after the transplant. If the patient is low risk, they would do very good. If they are high risk, they won't do very good, and this is the moderate risk group. And the scores are here. Less than 4 indicates low risk, 4 to 6 moderate risk, and more than 7 or higher is high risk. So this is a very easy way of determining who not to do the heart kidney transplant. You have a patient with kidney disease and heart disease, and use this score to choose between those who can or cannot tolerate the procedure. So if the GFR is high, they are the group that don't need the transplant. If it's low, and then you want to go forward, you see that in the low risk group, as I said, it's worth doing it. In the high risk group, you shouldn't do it. And in the moderate risk group, you have to go for other details and, let's say, expertise to decide what you should do or should not do. In conclusion, the cardiorenal syndrome is a result of many pathological dysfunctions coming together. We don't have a disease here, it's 2 syndromes coming together. So it's complicated, and when they come together, we have a higher mortality and morbidity rate. And to make a good decision, we need a multidisciplinary approach with timely and judicious use of all available treatment modalities to prevent or stop this vicious cycle. This is Mount Damavand, north of Tehran. I hope that you could come to Tehran and see it one day. Thank you.
Thank you very, very much, Dr. Shairf, and it was very interesting. Thank you for sharing your experience. And I think there are a couple of questions. We're limited to 3 very quick questions because it's We are already late, but it was very interesting, so we allowed 3 questions. In the meantime, if you can lower the volume because there is some resonance.
It's very interesting to hear this presentation. I just would like to ask you that you mentioned that in some cases with heart failure and kidney failure, and they can go for kidney transplant. Maybe what kind of parameters you really sort of give weightage when you recommend? Because this is usually patients with heart failure and dysfunction and renal dysfunction who often one will say that go for a both transplant rather than one. But in which kind you mentioned that okay they can. You have any parameters that you go sort of look at before you recommend that?
Quick question, please.
To be true, just as I said, we don't have a guideline to tell us what to do here. It's really easy when you've got a very advanced stage of heart failure, a globally enlarged heart, so big that it does look like a football, a European football actually, not an American football. And then you'll say, okay, this heart isn't going to respond. But if you look at the uremic patients, they do have large hearts, and we have seen lots of them respond to treatment. So actually this is one of the questions that we are trying to find an answer to.
I can answer this question real fast as well. As part of a large kidney transplant center as well. Generally speaking, the people that I cleared for kidney transplant who had a history of LV dysfunction, the criteria that I used was ejection fraction of no less than 20%. It had to be compensated heart failure, so the right heart catheterization demonstrated normal filling pressures on both sides, or at least the left side, if anything. I give a little bit on the right side. And the third thing would be that they should not have any symptoms regarding heart failure and their coronaries were revascularized and they had an ICD. Because the risk of sudden cardiac death is high, so they need to be treated appropriately.
I have a comment and a question. The comment is...
Leave the comment just to the question because we're late.
You cannot improve patients' heart failure with diuretics without producing some degree of hemoconcentration. And that's bound to increase the renal, improve or worsen the renal function. It depends if the patient has pre-existing renal disease or not. My question is, what would you do in patients whom you start them on diuretics and they develop some renal impairment? Would you use vasodilators? And have you had any experience with using high potency statins in patients who develop renal failure with pre-existing cardiac disease? Thank you.
About the high dose statins, I haven't had any experience working with that one. About using other kinds of medications, when you're treating a patient in acute heart failure, you go for all the available medications that you've got. So it's not only diuretics. You try to improve the situation by giving whatever you can, because you're losing the patient right then. Even if you have to, you go for an assist device. I'm not saying that for all patients. But one of the things that is important is that seeing a rise in creatinine when you are giving the patient a diuretic or other things like a vasodilator doesn't carry the same bad prognosis as we have with other kinds of increased creatinine. It might be some kind of